So I'll just start. So the topic the topic assigned to me is surgery for salivary gland cancer. So I'll just stick to that. So I think just a brief introduction that salivary gland neoplasms are extremely heterogeneous group of tumors, as already alluded to by Dr. Neha, with different biological and clinical behaviors. And so the most common salivary gland neoplasm is benign. We all know that. And malignant salivary gland neoplasms form a smaller part of it. And it accounts for approximately 3 to 6% of all head and neck cancers worldwide. And of the major salivary gland tumors, as already it was mentioned, we have major and minor salivary glands. So we're just going to restrict ourselves to the major, and of the major, the parotid gland malignancy are the most common. So most of the guidelines and whatever we talk is in terms of parotid tumors, and submandibular is much lesser, and sublingual is even less common. So I'll come straight to the surgical options that are there. There are guidelines which tells you when to go in for surgery and various situations. The ASCO guidelines of 2018 gives you a nice recommendations of various treatment, starting from the workup to the treatment, the management in terms of investigations, surgical, adjuvant, and in the recurrent and metastatic setting. So it's a beautiful publication which everybody can just refer to. So coming to the various options of surgery, you have these and a big list of them, and some of them are done only in benign sort of tumors, like for example enucleation, extracapsular dissection, partial parotidectomy, adequate parotidectomy. This conservative parotidectomy is used less frequently, but then the first four is used for benign, and starting from superficial parotidectomy onwards, the different kind depending on what extent of parotid is removed, the nomenclature is used. So these are the most commonly done among all of this, and as I already mentioned, the first three is usually done for benign tumors. Very rarely an adequate parotidectomy may be considered for a low-grade malignancy. But then upfront, it's difficult to be sure about whether it is low-grade or a benign tumor. But then if you have done an adequate parotidectomy thinking it to be benign, and sometimes it turns out to be a low-grade malignancy, we would probably at times, depending on the case that we are handling and what clinical radiological findings we have, we may just stop at adequate parotidectomy. But then that's not always planned. So what is always planned if you have a diagnosis of a salivary gland malignancy, that's what we are talking about right now, is superficial parotidectomy. That is removal of the entire superficial lobe. So what do we mean by superficial lobe? Is the part of the parotid gland that is above the facial nerve. So the entire portion of the parotid gland above the facial nerve is removed. So that is what is known as the superficial parotidectomy. So that's the minimum surgery that we would offer with the diagnosis of parotid malignancy. So this randomized trial was done for in a benign setting, so I will just not allude to that. So here. Again, coming to the classification of parotidectomies, what we were aware of is the what we are usually used to are superficial parotidectomy, total conservative parotidectomy when we save the facial nerve but remove both the superficial and the deep lobe, and radical parotidectomy when we sacrifice any of the structures like the skin or the most commonly the facial nerve, and extended radical when we do sometimes remove the masseter or the mandible depending on the invasiveness of the tumor. But here we have, the recent, paper which was published in the European archives, wherein they have given some sort of classification for parotidectomies, which is the most common, salivary gland that is dealt with, and they have divided, the parotid gland into various levels. And depending on which portion of your parotid gland you would remove, they have further classified it like this, parotidectomy 1 to 4, So, and that is the European classification, and and the one on the right side is the classification that we would otherwise use to, that we otherwise, are even still using it. So here it's sort of a bit of a complex sort of a situation, but we are not used to it. Maybe that's why. So this sort of classification will help us, help us in uniform reporting of the kind of surgery that we do for parotid malignancy. But then it's not, it's very often followed. But then just for the sake of completion, I'm mentioning it here. So this is a case of a 67-year-old lady with a parotid lesion, and the left eye closure, there was some paresis outside. FNAC was suggestive of a mucoepidermoid carcinoma, which we got it reviewed here at TMH, which was suggestive of a high-grade carcinoma. Now, in this sort of a situation, here the skin is about to be sacrificed. So here we are just definitely, dealing with some sort of an at least a total parotidectomy here. So again, just the same points that we just spoke about, and extent of parotidectomy, just to reiterate, as I told, for whether it's a superficial is the minimum extent of parotidectomy that would be recommended, and depending on the grade also we would many a times decide on the extent of surgery, and also not just the surgery of the primary, but then also the management of the neck will be decided accordingly. So we'll just come to that a bit later, the management of the neck. Now we'll just stick to the management of the parotid gland. So now one is the the grade, the other one is the T stage of the tumor. So again, if it is a low grade T1, T2, we would probably just finish with a superficial parotidectomy. T3, T4 would entail a total parotidectomy many times, and high grade lesions also would probably entail a total conservative parotidectomy. So see, while doing a parotidectomy, the basic philosophy is that in the presence of the facial nerve. So just to give a perspective, the parotidectomy is actually the surgery of the facial nerve, preserving the facial nerve. The most important structure that we are going to deal with during this surgery of parotidectomy is the facial nerve, and it's very crucial to save the facial nerve, whenever possible, because that's going to make a lot of difference for the quality of life of the patient in general. And it's very difficult to reconstruct because it takes a long time. Even if you resect and reconstruct, it takes a long time for the activities to come back. So whenever possible, oncologically, when it is safe, we always try to preserve the facial nerve. So what are the factors that, we'll again deal with the, how we go about managing the facial nerve just a few slides later. But I just want to tell you that the management of the facial nerve is at the center of, this surgery of the parotid gland as such. Now, with this, going with the facial nerve, the nerve monitors are being used off late, which has been shown to have some benefit. Most of the times we do use parotid, the intraoperative nerve monitor, especially in redo cases, when you expect the nerve to be at risk much more than in routine cases, T3, T4 tumors. It is most often used in those situations. But there is no compelling evidence. If you don't have a nerve monitor, there wouldn't be, it's not going to be a major issue. We can still go ahead with our routine parotidectomy without the nerve monitor. It's absolutely fine. But sometimes you tend to use these nerve monitors even for medical legal purposes as well. So, sorry, I think this slide came a bit earlier. I'll just skip that slide for the time being. So, intraoperative frozen section, I think Dr. Neha has alluded to that. Now, as a surgeon, do I use it, and for what and when do I use it? Now, this was, this picture on the right side is one situation where I would tend to use it. Most often in an FNAC, we do have, an idea as to whether we are dealing with a benign or a malignant lesion, and and most of the time our pathologists are able to tell us whether it's a low grade or a high grade neoplasm that we're dealing with. So it helps us in counseling the patient, the FNA. So FNA is an important aspect of the management. But sometimes when we don't have that situation, we would want to send the parotid gland after dissection to the frozen section to help us guide the further extent of resection, whether to complete a superficial parotidectomy to a total parotidectomy. If it is a high grade, we would end up doing that. And if our pathologists are able to tell us in frozen section it is high grade, that would be also helpful in us to go ahead with a minimum of 1 to 3 neck dissection. And also the other situation, and most often used other common situation to use, is the facial nerve. Here you can see in this diagram that this is the the main trunk of the facial nerve. This is the upper trunk, and this is the lower trunk. This is the zygomaticotemporal branch, and this is the cervicofacial division. And you see right at this junction, there is this tumor sitting on the nerve and infiltrating the zygomaticotemporal branch division of the facial nerve. And you can see that this section of the nerve is also red and beefy. It seems to be infiltrated to some extent within. So at this point, I will have to take a decision to sacrifice the nerve, but how much of the nerve should I sacrifice? Because that makes a difference as to if the stump is available here proximally and distally. That will help us in deciding how to reconstruct the facial nerve, because it is very important to reconstruct the facial nerve in the first go itself. If you're going to resect it, now the norm is to reconstruct it. So that is because the patient may not have any advantage of gain of function in the immediate postoperative period. The patient may also go ahead with an adjuvant radiotherapy, but then over the period of time, 6 months to a year, the patient patients may recover the facial functions over time, and it also helps in maintaining the tone of the muscles. There are studies which have shown recovery of facial function and also maintenance of the muscle tone. So nowadays the recommendation is to reconstruct the nerve in the first go itself whenever possible. And as I mentioned, our intraoperative decision making in the extent of resection and management of neck again does change. This is another patient wherein the facial division is being infiltrated by the tumor. So intraoperative frozen section does have a role to play during the surgery of parotid gland malignancies. Again, this is a systematic review showing the accuracy of frozen section for especially the parotid gland lesion. 13 studies with over 1,800 patients showing a sensitivity and sensitivity of 90% and specificity of 99%. Sometimes certain surgeons use it for achieving clear margins, but in my opinion, the margins in parotid gland lesions is sort of a flawed concept, I would say. But then that is a gray zone and it is debatable, but then that is my perception of or understanding over the years. Now, we've already discussed about the facial nerve, management. The other aspect is, we have seen in the pictures when the nerve is, infiltrated, we have to sacrifice, especially when it is a high-grade tumor. When it's a low-grade tumor, usually, the nerves are infiltrated when the, grade of the tumor is high, on the higher side. So it, as such, indicates the poor biology of that particular disease. And we would try to save the nerve if the pre-op pulse, if the facial nerve is functioning preoperatively. So definitely in those cases, definitely it is a must to attempt to save the nerve. And even if we do have to sacrifice it because of various indications that we just discussed, it is very important to reconstruct the nerve at the same go. But if the patient already had a palsy, then we can sacrifice the nerve. There's not much of a debate, and reconstruction would depend. If the nerve is infiltrated by the disease, then definitely you could think of doing a repair. But then if the nerve is injured due to the previous surgery that was done, and if it is more than 6 months, what happens is the motor end plates tend to undergo atrophy. So if there is a facial nerve palsy due to the prior surgery and it has lapsed more than 6 months, reconstructing the nerve is not going to be of much use, because the motor end plates are already atrophy. So in those cases, what is done is a facial reanimation procedure. So I will not go into the details of that, but just to mention, I have just said here. So these are the various options. The most common thing that is done is primary direct nerve, suture graft. Sorry.
Time, sir.
Yeah, I'm just done. And then these are the early reanimation and delayed reconstruction. Margins, I've already told that the extent of so we try the margins here in parotid glands are, I would consider it to be flawed, and there are absence of prospective randomized trials, is different anatomics, and we are trying to extrapolate the margins from the mucosal sites to parotid glands. And there are diverse histologies that are there, low grade, high grade. The same margins cannot be used everywhere. And the presence of facial nerve, we are dissecting through the facial nerve. And sometimes we have to go through the tumor to try to assess whether the nerve can be saved. So that's the major issue with the margins. So neck, when it is N0, we do a neck dissection in T3, T4 tumors or high-grade malignancies. Otherwise, we just do a level 2 sampling. If that is positive, we just complete the neck dissection. So the most common site of nodal metastasis from parotid is to the level 2. So that is why level 2 sampling, if positive, we complete the neck, or in a high grade T3, T4, we do a 1 to 3 neck dissection. That should suffice. We have just dealt with all of this. And yes, this was mentioned by Dr. Neha, and this study, I mean, since it is, I'm not going to go into the modeling aspect of it, but then what the reason why I put up here is that the extent of neck dissection that is done in salivary gland is close to 50%. So that is the extent of neck dissection that is necessary for a salivary gland lesion. So you have a SEER database, and this is the external database, which is our institute database, which also is more or less similar. For submandibular salivary gland, the minimum, if it is proven carcinoma, a minimum 1 to 3 neck dissection is what is recommended. Similarly, for the sublingual gland. And the problem here with the sublingual gland dissection is you could end up with a communication with the oral cavity. So reconstruction is a must in a sublingual gland resection more than a submandibular gland resection. So this is the guidelines that I was mentioning, and most of it is available in this guideline. And to summarize, superficial parotidectomy is the minimum surgery that can be offered to parotid gland carcinoma. Level 2 sampling in N0 neck, if positive, complete the neck. No robust data to mandate the use of routine IOM use. Facial nerve management is very crucial, and it is a center of the surgical aspect involving the parotid gland. Concept of margin in parotid carcinoma is flawed, and frozen section has limited value in salivary gland, but it does have some value. And it probably, it depends on the pathologists that have, and fortunately, we are fortunate to have, a pathologist who can help us, use frozen section more effectively. Thank you. Thank you for your patient listening.